Good evening, all of you. I'm very happy to bring from Kasturba Medical College, Manipal, the Department of Reproductive Medicine and Surgery, Manipal Academy of Higher Education, Manipal, Karnataka State from India. I am Professor Pratap Kumar, who I head this department, and we are having this adding pieces to puzzle on endometriosis. There are 6 modules. I bring greetings from Manipal to you. I have planned 6 modules, out of which this is the third one. The first one was endometriosis challenges in understanding the pathophysiology. I had spoken about it and it's still on, I think, YouTube there if you all can go through that. Module 2 was deep infiltrating endometriosis, difficulty in diagnosis and management by Dr. Alberto Vasquez Rodriguez from Spain. The third one is Dr. Sharan Sharma from United Kingdom, chaired by Dr. Narendra Malhotra. And the fourth, that is today, the module 4, 5, 6 will be subsequently broadcasted or it will be live. Module 4 is ovarian stimulation and its difficulty in endometriosis by Dr. Madhuri Patil from Bangalore. It will be chaired by Dr. Jaideep Malhotra from Agra. Module 5 is choosing the right medical management in endometriosis by Dr. Sonia Malik from Delhi. Chairperson will be Dr. Rishma Pai. And finally, we have endometriosis and tackling the surgery tips and tricks by Dr. Sevilla Raja from Malaysia. Chairperson will be Dr. Jayakrishnan. I now would like to introduce Dr. Narendra Malhotra, a very good friend of mine. He is very well known to everybody in this country and the world. Basically, he is a very fine person and technically is very good too. Director of ART Rainbow IVF Agra and Delhi, Managing Director Global Rainbow Healthcare, Director International Relationship of Suffolk, President in SARG, Professor Dubrovnik International University, Professor there, Sarajevo School of Science and Technology, World Association of Prenatal Medicine, Vice President, and also Vice President of Suffolk 2019 to 21, past President of ISPAT, past President of Foxy, and past President of ISA2, member FIGO Guideline Committee. I present you my very good friend, Dr. Narendra Malhotra, to introduce Dr. Sia Sharma, the speaker, and also say a few words on this module.
A very good evening to all of you. It's indeed a pleasure to be here in this wonderful modules which Dr. Pratap has designed from Kasturba Medical College. And it's my great pleasure and honor to introduce a very, very fine academician, Dr. Sia Sharma from USA. He's FRCOG, MD, DNB, DGO. He's a consultant obstetrician and gynecology at Queen Elizabeth Hospital, UK, Associate Training Program Director, Health and Education of England, Cambridge. He's been the examiner of RCOG, UK and Cambridge University, Associate Lecturer, University of Cambridge School of Clinical Medicine, Honorary Senior Lecturer, University of East Anglia, and his special interest, as we all know, is reproductive medicine and surgery. So I present to you Dr. Sia Sharma on pain in endometriosis, which is the most distressing symptoms which this very complex disease which it has. So Dr. Sia Sharma for all of you.
Thank you. Good evening. At the outset, I would like to thank Professor Pratap Kumar for inviting me to share my experience and latest research in the field of understanding the pain in endometriosis and its treatment options. I bring greetings from King's Lynn. It's a little bit about my journey. I come from Jaipur, the famous pink city in Rajasthan. From there, I moved to Manipal and I worked there for 7 years with Professor Pratap Kumar. And After that, I came to United Kingdom, and currently I am working King's Lynn Queen Elizabeth Hospital. This town is famous for, apart from my hospital, it has got royal residence of UK royal family. So today's plan would include understanding the pain, what is the mechanism, and what are the uncertainties in this area. Then we will also look into the treatment options of the pain in endometriosis, including pharmacological, surgical options, as well as the support mechanism in terms of psychological, social, patient support groups, and the network, and what is the future in this pain management. We are aware that about 2 to 10% of overall general female population suffer from endometriosis. In infertile group, up to 50% women can be affected with the endometriosis. Worldwide, about 190 million women and adolescent girls are affected during their reproductive.
Uh, Dr. Pratap, sorry to interrupt. I think there is some technical issue. I'll just play the video again. All right.
Yes, you start again.
Residence of UK royal family. So today's plan would include understanding the pain, what is the mechanism, and what are the uncertainties in this area. Then we will also look into the treatment options of the pain in endometriosis, including pharmacological, surgical, options, as well as the support mechanism in terms of psychological, social, patient support groups, and the network, and what is the future in this pain management. We are aware that about 2 to 10% of overall general female population suffer from endometriosis. In infertile group, up to 50% women can be affected with the endometriosis. Worldwide, about 190 million women and adolescent girls are affected during their reproductive age group, and some of them may be affected in menopause also. Up to 80% patients suffer from chronic pelvic pain, which is of variable duration and the intensity. Recently, the European Society of Human Reproduction and Embryology has produced their latest guidance in February 2022. Based on this guidance, they also have brought out a document patient leaflet about the information on endometriosis. Those who are keen, they can access this information from their website. The symptoms of endometriosis can be cyclical and non-cyclical, affecting the quality of life of a woman. Mainly the symptoms are in the pelvis and the lower abdomen, which includes dysmenorrhea, menorrhagia, dyspareunia, infertility, can be dyschezia, painful urination. Overall, it affects the body, causing fatigue and depression in the long duration. Endometriosis has got personal and social impact. Bearing on society in general is very huge, which cannot be measured because there are direct and indirect healthcare costs involved. At the personal levels, pain and infertility impacts on quality of life adversely. It doesn't spare even the partners and their families. There is a restricted physical functioning, everyday activities, and social life. It interferes with the education and the work. It also disturbs intimate partnership, affecting intimacy and the sexual relationship. All these negative impacts causes mental health and emotional well-being of the woman and their family. Dr. James Herrick, a great physician from United States of America, has said once that doctor may also learn more about the illness from the way the patient tells the story than from the story itself. I would like to share that some comments from the patient's diary, Priya's story. She talks about the taboo topic about endometriosis. She says so many women suffer silently due to what is seen as embarrassing from a social standpoint. Families tend not to talk to their daughters about women's health. She says, on my journey of trying to understand this affliction better, I have slowly begun to confide in those close to me, and those closest to you will also shower you with unconditional love and support. She says, I have been blown away by the number of people so close to me who have silently been going through the same thing. She says, my aim is to try and create enough awareness so that no one dealing with endometriosis will ever feel embarrassed to talk openly about what they are going through. Okay, so I would share with you another patient's diary notes. Claire says, every time I menstruated, I would be incapacitated in total agony for days. I was told that what I was experiencing was a normal part of being a woman and that I was just unlucky. I feel very angry that it had taken so long to gain a correct diagnosis. I feel devastated when I was told that it won't be cured. I felt very alone and didn't think that anyone understood why I was so upset and how much I was suffering. Despite how difficult living with endometriosis can be, I want women to know that there is always a hope and that you can regain the control. Another patient, Atima, she writes in a diary that it has taken me 30 years to get a diagnosis, and I know I am not alone in being told it is normal or just a bad period. I want to help to bring change and raise awareness. This endometriosis has impacted me in every way, my relationship, my friendships, my mental health, and my career aspirations. She writes further that I have only felt comfortable sharing my experience more recently due to the stigma attached to anything period related. More must be done. No one should have to wait this long for diagnosis or the treatment. Coming back to the mechanism of pain in endometriosis, historically, the research has focused on two things, endometrial lesions and adhesions as the primary source of pain. But removal of these lesions does not provide pain relief in all cases. 2 to 3 patients out of 10 do not have pain relief after surgery. There is also a dilemma because of the marginal correlation between endometriosis staging and the severity of the pelvic symptoms. The question is, are there any additional complex mechanism involved which we do not know? However, we know that in endometriosis, the lesions express estrogen receptors and hence they undergo cyclical bleeding and inflammation. This cyclical bleeding from the lesion and subsequent inflammation result in sensory nerve activation and altered activation of the nociceptive pathways, which I will be talking further. Large number of the immune cells facilitate menstrual breakdown during the menstruation. Similar thing happen in endometriotic lesions also. Endometrium goes apoptosis and necrosis and is then finally shed. This programmed cell death releases numerous cellular products such as iron and reactive oxygen species. Now I will talk about the inflammation and its cascading process. Let us focus on this diagram or this figure. There will be an inflammation in peritoneal cavity with a buildup of modulators or the mediators of the inflammation such as iron, reactive oxygen species, and all these can cause acidosis. There will also be an inflammation in the lesion or endometriotic spots, increasing the amount of cytokines and the chemokines and growth factors, along with the immune cells, macrophages, neutrophil, and mast cell. These two inflammation lead to neurogenic inflammation, and there will be raised concentration of prostaglandins, tumor necrosis factor, nerve growth factors. This huge inflammation activate directly the nerve endings and also promote or provide positive feedback for the inflammation. And this is called as peripheral sensitization of the peripheral nerve. From here, after activation of the peripheral nerve, the pain signals go to the spinal cord and to the brain then. So the enhanced load of the nociception or the nociceptive signals go to spinal cord and the brain, causing central sensitization. Another thing to understand, peripheral stimuli of the nerves, the signals go to spinal cord for the processing, and from spinal cord it go to the brain for the perception of the pain. So why this nociception happen? The reason is neuroangiogenesis. Initially, endometrial lesions do not have sensory nerve supply. It occurs by coordinated neuroangiogenesis. The new blood vessels are formed to support growth and survival of the endometriotic lesion. There is also synchronized innervation by nerve fibers called as neurogenesis. Hormones, estrogen, and the immune cells of the inflammation, they regulate neuroangiogenesis by producing vascular endothelial growth factor and nerve growth factor, which are increased in endometriosis. What they do, they exacerbate local inflammation and facilitate the growth of the endometrial lesions. This rich vascularization promote the blood supply and the support the growth of the lesion. So can we target this neuroangiogenesis? The best option is to early removal of the lesion before they establish nerve fibers innervation. So it causes reverse nociception. Hormone therapies significantly reduce nerve fiber density and also reduce estrogen receptor expression in endometriosis lesions. Reactive oxygen species induce oxidative modification of the proteins, and these oxidized proteins activate nociceptors, that is the pain receptors, which causes or promote the pain. So the antioxidants such as vitamin E and C, target these oxidized proteins and significantly reduce chronic pain by reducing these markers in the peritoneal fluid and the endometriotic lesions. Let us talk about the cross-organ sensitization. The different visceral organs share common nerve pathways, allowing cross-organ sensitization, causing localized, generalized, and deferred pain, and producing symptoms during menstruation, sexual activity, defecatory, and urination. Let us focus on this figure. The pelvic and lower abdominal organs, such as colon, bladder, uterus, and vagina, they are innervated by the sensory efferents through splanchnic and pelvic nerve pathways. Some fibers also travel through the hypogastric nerve. The central terminals of these sensory efferents, they terminate in dorsal horn. After terminating there, they synapse with the second order neurons in the dorsal horn and transmit the pain signal to the brain. Now, because these visceral organs share common pathways for the innervation from spinal cord to the brain, it causes a potential for the cross sensitization from one organ to another. Current therapies aim to suppress pain and delay reoccurrence of the pain or the lesion. The pain is multifocal, causing dysmenorrhea, dyspareunia, dysuria, dyschezia, and chronic pelvic pain. We all appreciate that it is rarely possible to completely eradicate the pain. The evidence suggests that medical treatment provides pain relief for more than 6 months in only 40 to 70% of the patient. And after the surgery, as I said before, 2 to 3 patients out of 10 do not have pain relief even after the removal of the lesions. Pregnancy plan complicate optimal treatment regimes. So we need to have effective strategies in patients who are planning pregnancy and who are suffering from subfertility. Coming to the treatment, we have 3 options of the treatments. One is the analgesia, hormone therapy, and the surgery. Whatever options we choose, the decision making should be shared with the patient. We should take into consideration the patient's preference, side effects of the option we are offering, the individual efficacy of the treatment, its cost and availability of the treatment option. Little about the hormone options. We can use combined hormone contraceptions orally, vaginally, or transdermal. We also can use them continuous or cyclical. If you are using only progesterone, they can be oral progesterone, such as the progesterone only pill. Intrauterine system, levonorgestrel releasing system, or the etonogestrel releasing subdermal implants. We need to consider the side effect profile in each patient. There are other options of GnRH analogs, including agonist and antagonist. They should be used as second-line treatment based on the side effect profile. And we also should consider add-back therapy along with these GnRH analogs. Lastly, the aromatase inhibitors, they should be considered as second or the third option in those patients where pain management is not being achieved. They are refractory to any kind of medical or surgical treatment options, and they can be combined with any of the above options. The non-formal pharmacological treatment for the pain focus on the quality of the life and well-being. However, no recommendations can be made because of the lack of the evidence. I'll be talking a bit more about this. So to understand through this diagram, the basic aim of the hormonal treatment is to suppress the ovaries so that estrogen progesterone production is reduced. So either we suppress the hypothalamus, pituitary, or the ovary, or maybe interfere with the estrogen production from the testosterone or androgens through blocking the aromatase enzyme. So non-steroidal anti-inflammatory drugs, they usually act on peripheral inflammation. They can be used alone or in combination with surgery and hormones, and they possibly prevent chronic pain. However, they have their own limitations because of the gastrointestinal side effects, and there is no evidence to say that they have any impact on the disease progression. Neuromodulators, which are used for the chronic pain, they interrupt central nervous system pain pathways. However, their side effects can be severe, and that is the dose limiting aspect of neuromodulators. Currently, we are using 3 types of neuromodulators, which include tricyclic antidepressant, selective serotonin uptake inhibitors, and anticonvulsants. Coming to hormone therapy, the mechanism of action is twofold for almost every hormone. They suppress ovarian activity by either directly acting on the hypothalamus, pituitary, or the ovary, but they also directly act on the steroid receptors and enzymes found in the endometriotic lesions. The evidence suggests that efficacy is very similar for all hormone treatments. The NICE in UK says that there is a significant reduction in pain visual analog scale, and quality of life is improved significantly. However, having said that, the efficacy and side effect profile can be highly individual, and in such patient and such situation, trial and error option is there. Combined hormones can be oral contraceptive pills, vaginal ring, transdermal patches. Continuous progesterone are available in the form of depot injections, mini pills, subdermal implants, and levonorgestrel intrauterine system. GnRH agonist and antagonist, the dose and duration evidence is limited, especially for antagonist. They should be used as second line due to their side effect profile. Hormonal add-back therapy is recommended to prevent bone loss and to prevent hypoestrogenic symptoms. Usual duration is about 6 to 24 months, or sometimes can be longer. The route and dose of the GnRH analogs can be intramuscular, subcutaneous, intranasal, or oral. There is no significant difference between the outcome in terms of the pain control, whether we take any route or any dose. The recent publication by Professor Dones using linjagolix orally between 75 to 200 milligrams and relugolix oral doses 10 to 40 milligrams, published by Osuga in 2020. Dr. Osuga is in Tokyo University, and I had an opportunity to work with him a few years ago. The safety profile of GnRH analogs, the poor side effect profile because of the hypoestrogenic state causes vaginal dryness, hot flashes, headache, and weight gain and acne. It also impacts the bone mineral density. It reduces depending on the dose of the GnRH analogs we are using. So the add-back therapy is recommended. It can be as progesterone only or the combined hormones, or selective estrogen receptor modulators, bisphosphonate or tibolone. The study shows that the add-back therapy improves lumbar spine bone mineral density. However, there is no impact on the femoral neck bone mineral density. The aromatase inhibitors, they inhibit the aromatase enzyme, which is useful in converting androgens to the estrogen. This is the reversible inhibition of the enzyme aromatase. And these aromatase inhibitors compete with the androgens for aromatase binding sites. They can be used alone or in combination with the other hormone treatment options. There have been meta-analysis including 7 studies using letrozole, anastrozole, oral or vaginal tablet, along with progesterone as add-back therapy. The side effects are very similar to GnRH analogs of hypoestrogenic state. Coming to the surgery, there is an overall improvement. Various studies have said that quality of life improved, pain scores are improved, and quality of sexual life is also improved. For complex endometriotic cases, the surgery should be taken at the center of the expertise to lower severe complication rates. Some specific points on the surgical aspect. The excision is recommended instead of the ablation on the peritoneal endometriosis. Adductolysis reinstate the pelvic anatomy. The ovarian endometrioma, a cystectomy is recommended over drainage and coagulation because this reduces the recurrence of the endometrioma and subsequent pain. The deep endometriosis should be removed surgically at the center of the expertise. Total hysterectomy with or without hysterectomy, oophorectomy, plus all removal of the visible endometriosis. Especially this is recommended in those women who no longer wish to conceive and all other medical or surgical options have failed. But we need to make our patients aware that hysterectomy will not necessarily cure the symptoms of the disease. Shakiba et al. Published a document in 2008, and they said that 90% of the patient would remain free from further surgery only up to 7 years. Beyond 7 years, some patient would need surgery. There is a risk of the ovarian failure after unilateral or bilateral cyst removal. Ovarian reserve is reduced, especially this is a concern in patients with the infertility. Surgery for recurrent endometriosis is more harmful to the ovary, and there are no prognostic markers that can be used to select patients that would benefit from surgery and predict the improvement of the pain symptoms. That is the statement from Guideline Development Group of ASHRI. Can interruption of the pelvic nerve pathways help patient in reducing the pain? Evidence suggests that laparoscopic uterosacral nerve ablation, LUNA, and presacral neurectomy, PSN, are not beneficial as an additional procedure to a conventional surgery. There is a high risk of intraoperative bleeding, postoperative constipation, urinary urgency, painless first stage of labor. There is a one Cochrane review by Proctor et al. And another review by Miller. Both recommend that there is a significant benefit in patients who underwent presacral neurectomy, especially in the midline pain. Non-medical strategies used to address quality of life, psychological well-being of the patient, and improvement of the pain. However, no recommendation can be made for following non-medical interventions such as Chinese medicine, nutrition, electrotherapy, acupuncture, physiotherapy, exercise, and psychological intervention. We all are aware and we always recommend that these options can help. But there is a less evidence and we are unclear whether they have any benefits or any harms. Support group for the patient is very important. Stephanie in her diary says, I wanted to set up a support group because I was disappointed with the lack of the information I received about my illness from the health professionals. Meeting other women with endometriosis is vital to coping with the illness. The support and empathy they can provide is a wonderful thing. It can prevent feeling of helplessness amongst these women. So we need answers for the effect of surgery on pain and quality of life in different subtypes of the endometriosis. We also need answer for effect of surgical treatment of superficial peritoneal endometriosis. The now sparing surgery is risk and benefit outcomes in centers of the expertise. The prognostic markers prior to surgery to predict a clinically meaningful outcome. To compare the risk, cost, and clinical outcomes between surgery and medical treatment in different countries and different cultural background would be useful. And also to define the potential benefit of non-medical interventions. We need further research because endometriosis is currently considered an inflammatory disease. Anti-inflammatory and hormonal control is not enough. The complex nature of the endometriosis can cause in 40% women non-cyclical pelvic pain. There's a delay in diagnosis, allowing complex disease progression and long-term changes in the pain processing. A personalized treatment approach is required. There is no more one-size-fits-all approach acceptable. So the future research should be based on ion channel levels modulation of the pain, targeting specific pain receptors at the lesion site and organs involved, to limit neuroangiogenesis to prevent lesions, innervation, and the growth, and direct modulation of the key targets on the peripheral nerves. So what are the possible future treatments? The receptor-based antagonist for the estrogen receptors, for the bradykinin receptors, and G-protein coupled receptors for the estrogen. These three antagonists can reduce hyperalgesia. They can also control neural sensitization. The receptor agonist or the activation of cannabinoid receptor decreases endometriosis associated hyperalgesia. Guanylate cyclase agonist, they reverse the neuroplastic changes, causing cross-organ desensitization. They reduce vaginal hyperalgesia and allodynia, and further research is needed in disease-specific changes at spinal and brain level. So the question is, can we exploit the changes in peritoneal microenvironment seen in women with endometriosis to treat the condition? Answer is yes, we can. A medication called as dichloroacetate, which inhibits pyruvate dehydrogenase kinase 1 enzyme. This drug normalizes human peritoneal mesothelial cell metabolism, and it reduces lactate concentration and endometrial stromal cell proliferation. So to conclude, the shared decision making is very important so that patients feel involved in decision making. There's a new evidence appearing for the pain mechanism. More specific treatment options are being researched, and support for patients and their families is very important. And I see future is very optimistic. Thank you very much. I would welcome to discuss and take your questions. Thank you.
That
Narendra,
was that was a fantastic overview of pain and endometriosis. We all know endometriosis is a very confusing disease. Some people call it an enigma. So when you call something an enigma, you don't know how to treat it. Some people call it benign cancer. Now, what is benign cancer? How do you treat a benign cancer? So with so many options, and yet not one better than the other, we are still at zero level on how to manage endometriosis, and especially if it is deep infiltrating endometriosis, those nodules which are in between the vagina. When you do a PV examination and you slide your finger on the rectum posteriorly, and at one pain, the patient feels severe pain, and that is where the nodules are. So these got to be removed surgically. So we need to do, as Dr. Sia said, a individualized treatment protocol and plan for all women. And please do not ignore chronic pelvic pain from adolescence to menopause. It was what we were taught when we said ectopic. Your any reproductive woman with pain and this thing, think ectopic. So any reproductive age group or any woman from adolescent to menopause complaining of chronic pelvic pain, which is not going by normal painkillers, think endometriosis. And if you think endometriosis, you will be able to handle them with anti-inflammatories, OCPs, progesterone only, or letrozole, or whatever, or surgery, of course. Surgery plays an important role if pain is there. And when you are giving them OCPs, they will not get fertility. So the fertility. So you have to match and mix. Who needs babies? Go for infertility treatment. Who needs pain relief? Goes for medical or surgical treatment. So that is what my take is on endometriosis pain. And thank you, Dr. Sia. Fantastically discussed all the brain receptors, how they go, the neuroangiogenesis, which is very important, and some new drugs which are in the pipeline and should be with us very, very soon. Of course, we have Endogest with us, uh, Dynogest with us, and Dynogest does suppress and does help in pain relief. But infertility we cannot give. That's what my take is in this talk.
Thank you, Dr. Malhotra.
Thank you, Dr. Sia Sharma, for the excellent presentation on pain. And as Dr. Narendra Malhotra said very well, because the pain is something which we have to understand and then give the treatment. And I also feel that in India, we are using a lot of Dynogest. Dynogest basically comes from 19 testosterone derivative. It's a fantastic drug for the pain. So I somehow feel the initial treatment, as you mentioned about early treatment, is better, especially for adolescent girls and perimenopausal women. And selection of Dynogest also seems to be good. You did talk about February 2022 guidelines of FSRA, and you also mentioned about the late diagnosis which happens in certain times. So the audience have sent a lot of questions, and the first question is same thing about active inflammation and deep infiltrating endometriosis. Do you want to explain once again about how this inflammatory processes causes severe pain?
So this is very important that we understand uh, endometriosis is associated with the inflammation, but how it impacts on the patient differently. So the active inflammation with the east cycle or on the long duration, if it happens in the ovary or the endometrioma, the same process, but it may not be that symptomatic until unless the cyst is very big and it is impacting some, causing some pressure, or maybe some adhesions around the cyst. However, if the same process of the inflammation in the deep infiltration, such as the rectosigmoid or bowel or the bladder, the acuteness or the intensity of the inflammation is very limited in that area. So the impact or the symptoms will be more pronounced in comparison to the cyst in the ovary.
Thank you. You did mention about the role of central nervous system and endometriosis pain. So we understand now how it is connected to the brain itself. So I also have found many patients who have actually, if you touch them, they'll say so much of pain. So I think you rightly said about how this nociceptive pain can kind of get into the brain, and their sensitization becomes completely different in their process of pain. So, uh, what about the gray matter, the brain? Is there any studies where they have found the central nervous system, especially gray matter, changes with chronic pelvic pain?
Yeah, I will comment first on the nociception. Very interestingly, because of the chronic nature of the overload of the pain stimuli from peripheral nerve to the central system, that is spinal cord and the brain, when central sensitization happens, when the brain neurons or the signals in the or the receptors in the brain, once they start having a constant chronic pain signals, so that these patients would have much more pain than somebody else with a similar amount of the inflammation. In these patients, because of the chronic overload of the pain stimuli, even with the less pain, these patients less pain intensity signal later in the life, they would respond very high, because such as, like, if I can compare constant excitability of the uterus sometimes in hypertonic contraction, similar thing may happen. Or I can give similar example. So the brains in the CNS, all these nerves remain heightened, so they will respond even to the small thing, and patients suffer a lot because of this nature. So this nociception or the nociceptive pain, which can be because of the inflammation, thermal injuries, or the pressure symptoms, it is always heightened in these patients. Coming to the second part of your question, sir, gray matter. The recent research has shown that gray matter is
Yeah.
shrunk or reduced in the amount in these patients. Now they are trying to find out whether we can predict the response or the what are the treatment options based on this finding. But this is a very early stage of the research and investigation.
Yeah, thank you so much. There's a very interesting question from Dr. Maninder Hoja from Faridabad. She's asking about any relationship of endometriosis to pollution, air and water pollution, as endocrine disruptors are responsible for so many new pathologies. Would you like to answer that?
Um, I don't have much information on this, but I remember from my postgraduate days in Manipal with you, sir. In those days, we were talking about various things in the environment or the nutrition, so and so. But I'm not aware in the current pollution or the current environmental factors which can influence or which can cause endometriosis.
Yeah,
Maybe you
I
want
agree with you because they act on like an estrogen receptor. So that's why the endocrine disruptors are something like an estrogen. So they are kind of increasing the estrogen kind of diseases, like what you mentioned about it. Another interesting question is that you spoke about irritable bowel syndrome, migraine, and fatigue. So would you like to explain again this cross connection you spoke about? You
yeah.
did mention about cross organ sensitization.
Yeah, so I think if you go back to that figure or the diagram I showed you from local inflammation lesion in the peritoneum, and also from the peripheral nerves to the central. Now, many organs, they share the common pathways, and all the, either through splanchnic nerves or the pelvic nerve pathways, or through the other nerve pathways, when they cross or they synapse in the dorsal root ganglion or the dorsal horn, and when they pass the signals, they get connected to each other. So even there is an inflammation or say endometriosis in the bladder or the bowel or in the pelvic peritoneum or back of the vagina or the, whichever area in that. So these patient can feel pain, and that's what I commented, that pain can be very localized, it can be generalized, or even it can be referred pain to the shoulder tips. Because of this central sensitization and cross connections. So that's the main focus on these days, that how to prevent. So the patient with the IBS or irritable bowel syndrome or migraine, because of the shared common nerve pathways, they can even have the similar pain.
Thank you. There's one question from Nagpur by Dr. Etani Chavari. Can Dynages be given in patients with infertility and endometriosis? Um, I think I did answer that. And Narendra Malhotra also said that how Dynages is basically given for non-infertility kind of patient. However, if
That's
somebody
correct.
has severe pain, and if you have not really understood the problems of endometriosis and you cannot pick up pinpoint where it is, you can always give a short trial of endometriosis and sorry, Dynages, because Dynages is a very good drug for relieving of pain. There's one another interesting question to Sharma. You mentioned about vitamin E and C. So one of the delegates asking, how much is the dose of vitamin E and C to reduce
I think
antioxidant?
I do not know the exact dose, but the study I referred was, I think, for 8 weeks they gave, and I think I'm sure dose system is different in India than UK, but it's not in my uh, immediate
So
memory.
60
That's okay. Anyway, we
60,000
can.
60,000 per week for 3 months is what we recommend for vitamin D. And
Yeah,
vitamin C, 500 to 1,000 you can take every day as a tablet, or even
yeah,
you can give a bolus injection of vitamin
Yeah,
C with glutathione in a drip, one shot every month, and that takes care of a lot of antioxidant. Or so we can do that also.
yeah. Sia
also,
Sharma basically says vitamin E. So vitamin E,
yeah,
what's that? 400 milligram per day, I suppose.
yeah,
400 to 600, yeah.
and this is
Yeah, that's interesting. And you also clearly said about Sia Sharma, you clearly said about how before the nerve fiber activation occurs, you have to start the treatment. And that's a wonderful statement we understood from your presentation. And I really feel that's a very important statement, what you said. And the nerve endings and nociceptive pain is something which we have really understood by your talk. And I think that completes the question from the audience and delegates. And before I really conclude, I would like to, I want to tell the audience that Tia Sharma is also an alumni of Manipal. He did post-graduation from Manipal, as I mentioned. And of course, he's an adjunct faculty for my department of reproductive and surgery. Whenever he comes to India, we'll call him to Manipal for giving lectures. And of course, Tia Sharma knows Narendra Malhotra for many, many years, right from his post-graduation days. And it's been a pleasure having you here, Sia Sharma, on this web online. And I must thank Akumentis Harmonica. We are missing the Supersit here. So he is always with us every program, but he has conveyed his inability to attend. I especially thank Dog Mode, who have had problems today because of the heavy rains in that particular area wherever they are transmitting. That's why the initial hiccups were there, and some could not log in because of some web connection problem. However, Narendra Malhotra would like to conclude, and then I would like to just probably say bye.
So thank you, Dr. Sia. Thank you, Dr. Pratap Kumar, for giving me a chance to chair this very, very fantastic talk on pain. Endometriosis is one of my favorite topics, which I've been talking since a long time, and now doing the idea scoring for endometriosis by ultrasound. So that is also a great new way of scoring for endometriosis by transvaginal ultrasound, where you do idea and classify them into EMOS and AMOS, and that also everyone should be knowing, because you should be diagnosing endometriosis early. So my punchline or take home message is: chronic pelvic pain, don't label all of them as PID and give an antibiotic for 5 days and that's it. Think endometriosis. And whenever you're doing a diagnostic laparoscopy, which you should not be doing only diagnostic for infertility, if you find minimal endometriosis like Allen-Master syndrome, peritoneal gaps, red lesions, uh, Coats jelly, brown lesions, blue spots, go ahead and fulgurate them, because this is the stage where the nerves have not yet infiltrated, and this is a stage they were painless. And if you just leave them away, this is minimal. Let me leave it alone. Please go ahead and fulgurate them. They will conceive faster and they will not develop into pain. So thank you very much once again, Dr. Pratap Kumar, Akumentis, for this starting this wonderful series.
Sia Sharma, would you like to say anything before we close?
thank you very much once again for giving me this opportunity. You commented that actually my association with Dr. Malhotra and you goes very long, almost 25 years plus. I met Dr. Malhotra first time in Jaipur sometime in 90. Sir, do you remember? You came to IVF center and I was junior doctor at that time. But it was a great pleasure to know you, to work with you, to learn under your guidance. Thank you very much.
So how is England politically with your Prime Minister gone today? We
Yeah,
hope an Indian origin guy will take over as the Prime Minister of
we
England.
all
That will be the best thing. Let's
we all
hope for the
wish.
best.
There's a big talk about that, but we never know.
So thank you very much, Dr. Sia Sharan Sharma, for the excellent talk, and then Dr. Narendra Malhotra for chairing the session. We conclude the session and say bye-bye to all of you. Thank you, delegates. We have more than 600 people listening and another 200 people in the Facebook connection. And this will be recorded and you can listen on the Facebook also. Wonderful. Good night. Bye-bye.
Thank you.
Bye bye. Good night. Namaste.